So the next part of the conversation we want to have is, and we want to make it more interactive, and I'm going to start with the panelists is to just shed some light with the rollout of 988, what it means, and what are some of the things that we're learning with this rollout.
988, who does not know, of all the people in the room here, who does not know what 988 is? Everybody's pretty familiar with 988? Interesting, I asked that question, I asked it for a reason. In January of 2023, a group of us assembled in DC for a 988 forecaster. So SAMHSA, along with the DOJ, CSG, Justice Center, and some of the leaders from around the country in law enforcement came together to talk about 988. It was fairly new, rolled out in January 16th of 2022, July, I'm sorry, what did I say? July, you know what I mean. July. So it was only about 6 months old. So we came together to discuss, what's going to be some best practices on how we approach 988. And we had some panels assembled to ask questions about what does law enforcement know about 988, how are they introducing it into their agencies, into the community. And I realized very quickly, nobody really had a good answer. And so I asked, if everybody in this room, there's about 100 of us, who in here's called 988? Who knows how it works? And I wouldn't expect you to call 988 unless you had a crisis, right? But I called it because I wanted to know how it worked. And I told them up front, hey, I'm just calling to see how this system works. I'm not trying to tie up your line. I'm going to hang up very quickly. But I wanted to listen to the response. And nobody in the room raised their hand. Nobody knew how it worked. And I'm like, how are we going to come together and kind of figure this out? Nobody in this room really truly knows how 988 works. So that was a good wake-up call for us to kind of get an idea that law enforcement truly had no sense about 988, how it worked. Their officers really did not understand 988. I traveled to a lot of different PSAP answering points for dispatch, and I would ask their dispatchers, when you get a call for a mental health crisis, if it's a low-level crisis, how many times have you transferred calls to 988? And I've had dispatchers look at me and say, what is 988? I don't know. So part of the issue was 988 was not rolled out. It's still considered a soft rollout. We're about to do a media campaign at the Justice Center separate from what SAMHSA is already doing to try to get a little bit more understanding about 988 and how that works. But there's some important things to know about 988. Number one, it's what the community was asking for. They wanted to be able to call a number other than 911 and talk to somebody and get a response, whether that's on the phone or in person if they needed to, without law enforcement showing up at their door. Okay, I understand that and I get it. And anonymity was number one key factor in establishing 988. But with that came some issues. For example, I'm here in Nashville. If I call 988 right now, my area code is 210. It's going to ring the tower in Austin, Texas when I call to ask for assistance. I'm not going to get a local resource here. Okay, that's a problem. Now, can they figure it out and transfer me to a tower over here? Eventually, yes. Do I want to wait around while that happens? Probably not. So they're looking at some legislation right now that would at least ping the nearest tower to where you're calling from, right? Not give you your exact location, but at least get you to the nearest tower. Makes sense. Another issue with it is, when you call 988, if you sit in the queue in some places for more than 2 minutes, it's automatically going to transfer you to the next available operator to another tower. When I was in, Kansas, Iowa, I don't know, I was in one of these places. After 2 minutes, it transferred to Illinois. And I was like, where'd the call just go? Because I'm watching it on the screen. They're like, boom, call's gone. I'm like, yeah, but nobody answered it here. Where'd it go? It pinged the next tower available call takers in Illinois. And I'm like, how does that help that caller? Like, this is not making sense to me. Well, they can text, chat. I'm like, I get it. But so there's some issues, right? But they went from 2 million calls to 4 million calls. So that tells me the community's using it. When do they use it? How do they use it? What's it used for? It's not just the old suicide hotline, crisis line anymore. This is truly a crisis line that was developed as an alternative response for police to address issues from mental health to substance use to resources. I know that larger communities have other numbers that you can call, 211, 311, all these other ones. 988 is very specific and an easy 3-digit number to remember to get your mental health crisis calls. Anybody in the United States and now Canada can call 988 and get somebody to answer on the other end of the phone. Law enforcement is trying to find a way to market this. Iowa City was the first police department to put 988 on their police cars, a decal saying for a mental health crisis, call 988. Now, was that a good idea? What do y'all think? Police cars are everywhere, right? You see it, right? 911, now you're seeing 988. The problem with it is, and it's not a problem, I love it, I think it's brilliant, but it's what message is that sending to the community when they see 988 on a police car thinking, well, I thought if I called 988, the police weren't going to be involved. Is that not something like, so that sends a message, right?
Yeah, and I think one gap that we've really noticed at the Justice Center and what we're really focusing that public awareness campaign on is messaging this out to law enforcement so that they're aware of the resource. I think SAMHSA's done a really good job of marketing this to other clinicians and providers but law enforcement really hasn't always had a seat at the table when it comes to 988. So, but again, that also brings up kind of Ernie's same point of, you know, if police, do we really want police to be the messengers, or are police the appropriate group to be the messengers of 988? They're responding to these calls, you know, they can say, hey, next time you could try calling 988 instead of 911, but how does that, you know, reflect to the community, and will they see it as another resource, you know, under the umbrella of public safety?
So therein lies a question for law enforcement. What happens when a call comes into 911 that meets the parameters, criteria to say, hey, this is low-level mental health resource call. We could easily transfer this to 988. Do you think law enforcement, 911, PSAPs are very excited about transferring a call to 988? No, why? Why not?
I'm not sure, but for some reasons, because from my personal experience,
Huh?
they just don't want to do it.
Okay.
And I know I've been to scenes, probably police officers, by the way, so I've been to scenes before where I know for a fact this is a mental health issue.
Mm-hmm.
And I try to call crisis response team. They don't ever respond. So, and when you touch these questions to do it, they don't do it.
Yeah. So part of the issue, is, and thank you for weighing in, is it's a liability issue in their mind. What happens if we transfer this call to 988 and they end up sending maybe a mobile crisis team out there, or they don't send a response and the person ends up dying by suicide? Maybe it couldn't get resolved. Or maybe they send a mobile crisis and then something really goes bad. Okay, so you get this liability thought process from leadership. But I'm on the other side of the fence. I'm like, what if you send a law enforcement response and it goes bad because you send a law enforcement response? We've seen this. Don't stick your head in the sand and act like it doesn't happen. It happens, and that's why we're having this discussion, right? There's some guidance that just came out, I think, that is going to be a game changer. It came out May of 2023. The BJA, along with the Vera Institute, the Bazelon Institute, came together based on, one, what happened in Minneapolis, and two, a lawsuit that was filed in DC when it came to the type of response that's being sent to a mental health crisis call. So I'll set the stage. If you call for a heart attack, who are they going to send? There you go, no brainer, right? I'll give you that one. You didn't even need to phone a friend. Yeah, they're going to send EMS, right? Because you needed a health response. For a mental health crisis call, the American Disabilities Association Act. I'm sorry, I knew you were going to say it. It was coming. I was waiting for the slap on the head. The ADA I'll just do it like that, stay safe. Has deemed mental health calls requiring a health response. So if you would send an ambulance to somebody having a heart attack, you should, if you have the appropriate ability to send a health response to that community member, you should be doing it. So I'll give you some examples here. If all you have is the police to send, then that's what you're going to send. But now you have 988, like Denver Star, you've got Denver Star. You can easily triage this call and say, we've got that ADA concern covered because we're not going to send police to this. It's a health response, right? They're up and running the program and setting the trends that other places are following. But what if you don't have that kind of community response? What if you don't have a co-responder model? What if you just have law enforcement? Right? And you know the old saying, if all you have is a hammer, everything's a nail, or whatever, vice versa, right? So is 988 now an option for an alternative health response? Could it be looked that way? I think it can be looked that way. If you're a dispatcher and you're getting this call and it's, hey, I've got somebody that's depressed, that's looking for some resources, no need to send an officer out there. I tell you what, let's transfer this call to 988. Who's going to be able to pull up those resources and get that help to that individual? That's how you avoid the problems of sending a law enforcement officer out to these types of calls that can go wrong. So the guidance is out there that you should have other resources in place to be able to send to a crisis call. I think that's going to be a game changer. I truly do. Agencies have, like, this is not widespread yet. It's not out there amongst a lot of law enforcement agencies yet. I think you'll see this come out probably at the turn of the year. They're really going to get on board with this. Agencies that are under consent decrees right now, they know about this because they're building out these types of alternative responses to address these types of issues. So 988 in and of itself, I think, is an amazing resource for communities. However, there are still some logistical issues to work through. 911 took 10 years to kind of get up and running and be established. 988's only been added coming up on 2 years. So it's going to take some time.
And I think, because 988 is run differently across the country, right? Every state has a different 988 system. It's been difficult to look at best practices, right? Because it doesn't necessarily apply maybe in your location, which is another challenge as well.
And that's a good point. So if we have, I would say, Tennessee, Florida,
Right.
Colorado, right? So Bob, why don't we start with you and get your perspective on this? So 2 issues that Ernie you raised. Location-based services is an issue, number one. Number two, information sharing or call transfer depending on the liability issue. So we'd love to hear from you, Bob, then Sabrina and Brian. So Bob.
Sure, I'll start. So location-based services was difficult for 911, as you know. It took a long time to be able to find a location.
Bob, you're
in the last really 3 to 5 years. And quite.
Bob, you're
I'm breaking up. Okay. Let me turn off my video.
Sure.
Maybe if I turn off my video, it helps.
Yes.
Does that help? Okay. I was just saying, location-based services took 911 a long time to figure out because we generally had tower location, and really that's been solved a lot because people use mostly wireless phones, and they're usually Apple or Google, and both those organizations or companies helped work the emergency service location-based problem out. So 988, it is.
You're still breaking up. Bob, you're still breaking up. All right, so why don't we just go to Sabrina you and share your thoughts?
Yes.
Okay. Bob, can you hear us? Bob, connection is really bad. You're breaking up. Ashwini.
I think one of the things that you said was, that I thought about when you said our dispatch agencies transferring calls. And first thing I thought about was not necessarily liability, but criteria. And I think we need to do a better job, even as dispatch agencies, making sure that the call takers understand the criteria. Because I know for the most part, if they ask for it or ask that I just need somebody to talk to, we'll give them that number, transfer them the number. But other than that, we probably are sending them a response. And that was even before we had the other opportunities for them. We were just, if they didn't ask for that, we just sent it. And I think that's more of a thing of getting that criteria out there, because we have 988 plastered all over. We put out things for when it came out. It was big. We made sure it was well known. But we didn't really talk about, well, when do you send it? Put it out there so you know that it was there, but when do you actually use it? And I don't think that was really something that was talked about as much as just to be in there. Here it is. Okay, well, when do you use it? And I think that's something that we need to talk about more. And another thing I thought about was it's not so much as when the caller calls us. What we have issues with when 988 calls us, and they're trying to find somebody, because we have policies in place for them wanting us to ping phones that we can't do. And so that is where the trouble comes in. It depends on what information that 988 has, whether or not we can ping that phone. Because we're getting a lot of mental health, even before 988 mental health centers, that would just call us randomly wanting us to ping a phone. Well, if they say they're here, no, they just picked us. Can't do that. And that is a liability, and that is something we can't do. So I think we need to work on getting the cell phone companies, at least the major ones, AT&T, AT&T, Verizon, T-Mobile, and work on getting that criteria that if it's a 988 phone call, that allows BPSAP to go ahead and get that information. Because the only thing now is if they haven't said enough to say specifically that they are, they have to have not called 911, or they have to have been here in the area and be in danger.
Yeah.
If we don't know where they are and they're in danger, we still can't pick the phone. And that creates a time crunch. And we have done it sometimes, and even though we're not supposed to, and the person was in Texas. So then we've had to call Texas, and then we put ourselves in the middle of something that we should not be in the middle of. And then that goes back to even more confusion.
Yeah.
So
which right? I said I'm from Texas, right? So if I were to call right now in 988 in Austin, Texas, says, oh, this person's a threat to themselves, we need to get them some help. How are they going to find me? Because now, what you're hearing is it may be a liability for us to ping that phone if we don't have the information we need to build that criteria. So you bring up yet another good point about that. And at the end of the day, we're talking about citizen safety. What can we do without encroaching on their anonymity or their privacy, but in order to bring them the help and the safety that they may need.
Right.
What we did is, in the beginning, very much, we had an issue with liability. We were scared. Not so much just even to the point of, well, during the transfer, what if a caller gets disconnected? Sort of even down to that level. So what we decided to do, and we're sort of lucky because we're a completely civilian agency, so we don't have to check with a bunch of people. We just make the decisions ourselves. We said, okay, when it comes to transferring calls, when it comes to identify what 988 can do, let's go straight to the provider. So we went straight to the contracting provider for the state of Colorado and engaged them and said, what calls can we give you? How can we set up this open line of communication between the two of us to really figure out what's best for the callers? So instead of dialing to 988, we have a direct backdoor line into them that we can transfer into, and then we have them set up sort of like a mutual aid provider. If an outside jurisdiction calls in with something, 988 will call in on that same line, and we've taken the time to educate them on the resources that we have, because they do have mobile crisis in Colorado, but it's nowhere near as robust as the STAR program or even programs in other jurisdictions like that, because with our mobile crisis, it has to fit a very strict criteria for them to respond. And even if they do respond, it might take up to 4 hours to get somebody there.
And they bring police a lot.
And they bring police a lot. So we just sort of overcame what concerns we had by dealing directly with the provider to make sure we could all be comfortable in the situation.
Thanks. So I know Bob is joining again. Bob, can you hear us now?
Yes, is this any better?
Oh, much better.
Okay.
Sorry,
If
go
I
ahead.
lose this, I'll just call in on the phone if this doesn't work. But there was a good parallel in 911 to this that maybe will help us think through it. You know, probably up until 10 years ago, the level of service, if you called 911 and needed CPR, would depend greatly on where you were. And a lot of it was a question of liability. There were law enforcement dispatch centers that would not provide CPR. I listened to call recordings where people would ask for CPR instructions. Oh, we're not allowed to give that. It's a liability. And people would die at home because there was no CPR. Other agencies would provide it and understand, saw that as a liability for not providing it. It took, like I said, probably 2 decades for that, for even a majority of the 911 centers to begin doing that. And then even in the end, it was finally legislation, and it's state by state, because 911 systems are state by state, that require that. And Florida required CPR, it's been probably about 10 years now. So it's very similar to mental health. There needs to be an understanding of the liability. There needs to be best practices so that dispatchers in various systems across this country can be trained and know what's best and then have their and then how do we refer these? Do we refer them to the 988 centers, etc.? So I think we can get there, and hopefully faster than we did with the whole CPR. But I think it's a very close parallel that we can use to be able to educate, get the understanding, and really relieve that liability from those ECCs, thinking that, if they hand off this call and something happens, or person commits suicide, whatever, that they don't have that liability.
And I think that's a good point, and I think Sabrina, you raised up a good point, liability versus criteria, right? And I think also the restrictions from the technology. So before we move to other topics, I just want to see if you guys in the room have any thoughts or questions. Mark?
One thing I've not understood, I'm sure y'all can answer this, what is that mechanism? If I call 988, in my mind there's a call acuteness scale here that maybe that person does not need an in-person response then, but sometimes they may. What is that transfer mechanism to get somebody on scene? Does it go to 911?
They don't transfer the callers. They don't transfer the caller. They keep the caller.
They keep the call.
And if the caller doesn't tell them where they are, that's when they call us and want us to pick the phone. And that depends on what they know as to what they can do. And that's where we're talking about life-saving versus liability. And we need to figure out and get past that point and figure out that ground so we can get to the life-saving. And that's where we're stuck at sometimes. And so we're stuck on this. We need to just get to the life-saving. How do we get to the life-saving past this point of liability? And I think for me, when I talk about it and I look at it, and been doing this for many years, we always end up with, when we call the cell phone companies, it's something based on the cell phone companies. And I think if we can get 988 with the cell phone companies, I think we can get past it. Because if they have a criteria allowing 988 phone calls to be, tell them it's a 988 phone call, and they say, okay, we'll give you the information, and we just give them the operator number from 988 or something like that, I think if we can get to them on board with something like that, then we can get past it. But right now, other than that, it is a liability. So I don't know how that would work.
Yeah, the acuity on these calls, and I'll let Brian jump in, is, there has to be danger to yourself or others, right? Immediate. And what they have found on some of these calls that have actually gone to dispatchers, there's been calls that have been, quality assurance that they've listened to, where a person calls in, they're suicidal, but they're never asked, have you already done something? Have you already made an action A person has, I have access to all this medication, but they were never asked, did you already take some? Right? So they have to establish acuity of the crisis, if there's danger to self or others. I know for mobile crisis, there's usually 3 ways to kind of categorize those. One is emergent, and these mobile crises are usually funded and set up by the state for their local mental health authorities. And if it's an emergent response, usually mobile crisis has about an hour to respond. If it's urgent, they have up to 8 hours to respond, or if it's routine, they have up to 24 hours. And that may be different. That's how it is in Texas. So it could be just based on what is the need of the caller, but if it's something that's imminent, it's going to need a response.
Because one of the big dividing lines with who we send on responses in Denver is if you have an active plan. I'm going to kill myself. This is how I'm going to do it. I have the resources available to me. Those are the big ones when defining acuity about what type of response you're going to get.
Can I go back to that technology? So whoever was commenting in the room before Ernie, there was a comment that came up. Can I address that real quick?
Sure.
So it's important to realize that a 988 center, if they've got a call, you cannot just transfer to 911. That center may not be located in the same area. If they were to dial 911, it would actually be the location of the sender, or of the crisis center, not the location of the caller. So they have to transfer those to 10-digit phone numbers. Some agencies have emergency 10-digit set up, some do not. That's something that needs to work out in itself, just because that lowers the priority of a call when you're calling in on a 10-digit number more than often. But then it's also difficult in times, for example, here in Collier County, there's one agency covers the whole county, so it's fairly easy if you do have the caller's location too. And quite honestly, this is how, unless it's within a state, they may Google the number. That there's no real easy way to find the 911 center, the dispatch center in an area. That's problematic nationwide, again, because it's not a nationwide system. Fairly easy in Collier County. If you're across the I-75 on, Broward County, Miami-Dade County, there's dozens of 911 centers. So locating the correct one where the caller needs help could be very difficult for a 988 center, and that's something we have to work through. The state of California 911 office through OES, I know they used a grant, and it was a mental health grant. I'm not sure which one it was, but they took over the ability to route, and they have very strong 911 at a state level, again, versus county or regional level, so they were able to do that. But they are building the 988 system into their 911 system, so they don't have those issues. But that's one state, and so this is something that needs to be done and looked at as we talk about this nationwide. And we don't get a lot, in our agency, we don't get a lot of call transfers from 988, but because our community is made up a lot of, people that come down seasonally, people that are down here on vacation, a large number, if not a majority of people with wireless phones do not have local area codes. So going back, looking through our call transfers from 988 centers, they're not from the local 988 center. They're from different parts of the country. So it can be very difficult, that resource, to be able to locate, okay, where's Collier County, where's Naples, and what's the non-emergency number that I can transfer this to, because at this time, in most states, that's the only way they can transfer a call, is on a non-emergency line. So we've got work to do.
Thanks, Bob. Any other questions?
Sure, go ahead, Mark.
Do y'all have thoughts on, is the best approach here to say, public, call whatever number you call, we'll figure out what response should be, versus putting responsibility on the public to, in some way, shape, or form, know, I need to call this number for this number for that. It feels like what we're trying to do now is unpack the last 50 years of call 911.
Right. Go ahead.
Sorry, part of it from our perspective, so one of the things, we are somewhat unique in the way that we're an all-civilian agency. And when you talk about trust of who to call, it was brought up before, that's one thing, the reason I keep saying we're a civilian agency, because that matters a lot. when somebody calls in for STAR. So there is that trust issue that must be established. So I completely understand what you're saying. Like, you have this Rolodex of all these different numbers, but if you give people the options, are they more apt to call them if they know that, you know, police isn't going to be part of it or medical isn't going to be part of it, that they're not as apprehensive to call. And that's one thing we really focus on, is getting education out too, to try to make sure that people, we'd rather have them, you know, remember the numbers and call than be apprehensive and just not reach out because they're afraid of what the outcome might be.
And I think, you know, I think it's a little bit of both, right? There are folks who 911 was drilled into their brain and that's who they're gonna call forever, right? So you have to make sure that the 911 call takers and dispatchers are trained in order to say, hey, this actually isn't a 911 issue, we can transfer it. But, you know, giving folks kind of a no wrong door approach, right? If you know the number, great, call it. If not, 911 will figure it out as well.
And we're slowly adding, to try to be that one-stop shop, slowly adding other stuff, like taking advantage of nurse lines and things like that, because we all know 911 is the sort of the gateway for a lot of people, for the criminal justice system, for healthcare, for everything, because everybody knows who we are. So that's one thing we're trying to do, is at our level intercept as many of these calls as possible and get you to the actual care you need, because we all know that for a lot of times, if somebody's calling in with a low acuity medical issue to 911, they don't need to go to an emergency room. So if we can get them to a line that, you know, connects them with a clinic, with appointments that way, you know, selfishly, it makes it easier to run the, you know, the ambulance system, frees up resources, and gets the people the help they actually need, and it's a win-win. So
And I think you also have to look at, when you're dealing with a person who's in some kind of crisis, they're not gonna remember everything. They're gonna remember the easiest number they can remember. 911 is the easiest number. So try to expect someone who's going through something like that to remember all these different numbers when 911 is supposed to be doing to as a kid. You can't really expect that. Another thing, Bob, I was thinking of what you were saying, and it made me think of this. I wonder if we get 988 people to have access to the NIDA ERPC that has a list of all the 911 PSAPs across the country and their numbers. Just made me think of that.
Does everybody know what ERPC is? So Bob or Sabrina or Brian, if you can just talk about what exactly it is.
It's the Enhanced PSAP Registry and Census. It's with Geocom, and they have it, it's just a database, it's a web portal and map, and it has all the information on each public safety answer report throughout the United States. So you can, and you just sign up to be a member like I'm a member, so I can go on if I'm trying to transfer somebody, I'm trying to help somebody, I can't figure out who it is or where they need to go or what the number is. I can't Google, if I Google and I can't find it, I can go to the ERPC and look it up. So I wonder if that'd be an option, maybe. When he said
Yeah, it's a very good tool. It's a very good tool. And conversely to that, Sabrina, is for 911 to know the best center to be able, 988 center to be able to track, to transfer to if it's non-life threatening and the person needs resources. You know, the reverse of that is also very important.
True. But at least maybe get them in the area. Maybe. Hopefully. Possibly.
So that brings me to the next point, and Mark, thanks for bringing that, is about, I know we talked about call transfer, right? But also sharing of information. We all are collecting a lot of information. To streamline this process, we got to figure out, I know we already addressed some of the challenges around CAT, like all of that, and of course if you have one solution, then it's easy to work with, but the reality is that in same jurisdiction, you might have 4 or 5 different providers. So when it comes to information, can you guys share your thoughts, is that what the current landscape looks like, what the challenges are, and what we got to do to fix this, because we are a partner in this, right? Whether it's 911, 988, or public, we collect a lot of this information, and in time of crisis, every single data point matters, right? So can you talk about is like what the reality is when it comes to sharing the information across between 911 and 988?
Yeah, well, I'll use Salt Lake City as an example. Right now, they've got a good, Salt Lake City PD's got some good data that they have collected on calls that they have transferred to 988. We were looking at an agency in Colorado, Inglewood, that was, they took on an agreement to transfer calls But it just seemed like it never really got up and going. It started, they did 10 calls right off the bat. 2 of them had to come back to 911. So on paper, you're like, oh wow, 80% of the calls are handled by, yeah, you're talking 10 calls. Salt Lake City's got, they're in the hundreds of calls that they're transferring. So it's going to be difficult to really get that data information right away because there's just not enough agencies that are in the process of transferring the information. Now the information that we are, if we want to bring the conversation back to these police mental health collaborations and the information that Bob's helping provide technical assistance to these agencies is what information is important to collect in order, and we were talking about analytics out in the hallway on break. That seems like when you get the best question, somebody comes up to you on break and says, hey, well, do the analytics, prove that these programs can be beneficial for sustainable funding in the future, right? And then if so, what do the analytics look like? What kind of data are you collecting and then what are you sharing? Because that's truly where we need to know, is it worth funding these programs, right? I just helped write a letter to ask for $40 million in more mental health funding from the Senate because we're trying to expand these programs. What the difficult we're having is what information are we collecting and does that translate to these systems and these programs of being successful? So how do you define, you have to define what success means for these agencies, and success can only be defined by the data that you're collecting. So are you measuring that by how many uses of force are these programs collecting on data? Do we show that there's a reduction in use of force, or are we showing, hey, we were able to divert this caller who was a high volume caller for law enforcement time and time again, we know, and divert them now into a treatment program with some follow-up and case management to now these calls are being, there's a reduction in calls for emergency services, which can help the acute healthcare system front door from being overloaded. So how do we define success? I think that's important if you look at it on a grand scale. And that's why I think it's so important that IJIS comes in and helps these agencies to set up these dashboards to say, hey, this is what success looks like. How many calls are you going to? How much time is being spent on them? Is force being used? What are proper outcomes? How many are being connected to treatment? What does treatment look like? How long does a patient stay in treatment, right? You have to collect all this information so then when your funders are coming to say, hey, show me why this should be sustainable. Why do we need to continue with seed funding or should you have line item budget funding for sustainability of these programs? So I think that's one of the things that we see struggles because, again, you have these different, like Brian said, you have different platforms. RMS doesn't talk to the AFR systems, doesn't talk to the emergency EMR, whatever systems that the behavioral healthcare providers have. And so many of these agencies just fall back to the old Excel spreadsheet. And is that a proper way to really collect data? I mean, it's difficult. It's a grind. And Bob, I mean, you're providing technical assistance right now on behalf of CSG to agencies that said, hey, help us. Is that still seem to be the trend that you're seeing, is that they're having difficulties with whether it's the MOU or trying to get these systems to work together to collect the data they need to show success?
Yeah, the ones I'm working with are having trouble getting the data from the other agencies and compiling it and convincing them that they can share the data and how they're going to use the data, so they're more willing to share it. And so the ones I'm helping are the ones having trouble with it.
Yeah, and not to change the topic of mental health, but I'll tell you this, Carly and I are working on a project right now where we're helping a university study their data on traffic stops to look for disparities in traffic stops. And what data points are they collecting? What are they sharing? They didn't even want to release the first report to us. They're like, oh, you'll have to wait till it becomes public. I'm like, we're going to be the ones helping you analyze the data, to look at, disparities in traffic stops and where are these happening, and then how do we mitigate these disparities from happening. So it's crazy, that information is going to drive the bus to success, but it's mine, and I don't want to share it because X, Y, and Z.
So Ernie, you bring a good point. There are three, like I'll say, three different lanes you should define just from the information, right? Information between the two partners, like 911, 9A, public safety, I'll say, justice and public safety with public health, and then also the KPIs, right? So we'll love to hear, Sabrina and Bob and Brian, your thought is how you're sharing data. If not, I know what is, you did brought the whole data sharing agreement in your opening remarks, so we'd love to get your thoughts on that.
Yeah, with data sharing, so we do identify in the CAD system. So STAR's run just under 17,000 calls since its inception, but we've identified over 41,000 calls that are actually STAR eligible. And so when you look at the CAD at these calls, when you have different responders going, there is a shared incident ID number that is shared between all the agencies, all the responders. So there is that central point we can all go back to. It's just getting everybody to agree to release that information. And that's the number one thing. You get legal departments involved as to, what can you actually give to others. And it makes it much more difficult to say, hey, what are the true impacts? We know we're responding. We know how many calls we've responded on, but what are those other impacts that aren't as measurable just with the CAD data that we need, patient care reports and other stuff to sort of supplement that. And that's where we're headed. Lots of discussion, lots of data sharing agreements. But that's sort of the next obstacle. It's going to come. It's just getting everybody on the same page. Sabrina?
I think one thing that, like I said, has helped is national program is going really well. Thanks again. Appreciate it. And I think they've got it, the police department, we're a separate entity as well. We are our own department, fire department, police department, dispatch is our own department. We're public safety, but we're separate from them. So when I'll say we, but we're still a separate department. But the police department is very excited about this and excited about the data from the last few years. So it's plastered on, they have a whole section on their website. So that is good for them. They've broken it down, and I have the last couple of years here if anybody wants to see it. They've broken it down into the pie charts and every chart you can imagine, and all the data and how it's done, each sector, how it's progressed, and things like that. And so I think it's because it's done well, it's out there. It's when you're not sure how it's going, if it starts off slow, is when they try to we're going to hold on to this for a minute. And so because it's done well, it's out there. But that's the catch. Because some things will start off slow, and that's okay. But they don't want you to see that when it starts off slow.
I'm very jealous they're all city employees.
And I guess some encouraging news, and the timing's very appropriate, is there's a lot of interest right now in breaking down data silos and standardizing data, and then being able to share that data, especially with new next generation technologies coming into play in 911 as we move that whole system further. Just yesterday, the National 911 Office under NHTSA, their website's 911.gov, is working. They have a strategy across several federal partners and state and then local agencies, and even the public safety agencies, APCO and NENA, are discussing how do we do this. And so it's not just mental health data. We do need to define that, standardize it, and the experts in those fields can help with that, obviously. But from a perspective of getting that, from the local agencies, again, because of our, not only do we have our own systems, but we have our own way of talking, our 10 codes, dispositions, everything like that across the country, but we're looking at how to share that and get it across now that we're going to have, at some point in the near future, a national 911 architecture. We need to be able to share that data more than just with the agency next to us. So there are some hurdles, but I think we'll be able to work through them rather quickly as we work on both the standardization and the interoperability of the systems and sharing that. And it would be interesting, and it would be something that I think IJIS should directly be part of. And again, if you look, it's called the data path at 911.gov, and you can see they have a strategic plan and have identified what's needed to overcome that, but behavioral health fits right in it.
Thanks, Bob. Thanks on that good note. Just so you know, side note, we are part of that conversation. Actually, 911 office took the architecture that we created 6 years back. So that's good news.
Okay.
And so we've been working with APCO and NINA on the data standardization piece because we have, in our work in justice, health, and correction, we do have data sets around, I would say, just health itself. Behavioral health is just one lane of it, right? So my question is that, do we feel the same comfort level? I know 988 was just launched. Can 988 learn from us the good work we have done and the standardization that we're talking about? How 988 can benefit from this? Are we having those conversations with 988?
Yeah, I think it's early to tell because you got to remember 988 is going to be run individually by each state. So I think that herein lies part of the issue is, the states have to fund it. You're going to see the charges on your cell phone bill. If you don't believe me, look up your cell phone bill. You're going to see a couple $1 charge here and there for 988, which is okay. But I think that's going to be a challenge. You're going to have to get states really because if not, it stays decentralized. And when things decentralize, you don't have no continuity.
Other thoughts? I know we have a few minutes left, so we'll love to go around and Bob, I'll start with you because I know you're doing the TA. What are some of the lessons learned?
Well, one of the things that and again, I'm working with grantees that are just sort of getting started, so it's not an example of the maturity that's out there. But one of the things I've noticed is they've been very creative at working around these issues to get the answers they need. But I've also noticed that, and we've talked about this, the public safety side has objectives to determine this, and the behavioral health side has different performance measures that they want to see. And I think it would be very helpful if they would get together and agree upon a comprehensive set of what we want to know from this data. I think it'd be a lot easier to be willing to share data if everybody was in agreement of why we want it and what it's going to show. A good example is from the law enforcement side, one of the things I would want to know is, are we keeping Phil from calling 911 6 times a week because he has a mental health breakdown, when that could be handled by the mental health folks once we diverted him, and then keep those calls from occurring. To me, that would be a big indicator that what we're doing is sort of helping. But then on the behavioral health side, are the people, is Phil getting hooked into resources? Did he show up? Did it work? And did he not even need us anymore? That's what they care about. 911 really doesn't care. If you stop calling them, then they sort of can show that worked for them. So those are the kinds of issues. Another example, one of the grantees, the behavioral health group, has developed a Google sheet where they keep all of their data, and their people on the behavioral health side enter it live. So that sheet's up to date all the time. The police department involved won't allow their people to touch the Google sheet. So they have a clinician on contract. She completes the Google sheet manually from the police reports, and then she enters it into the Google sheet because she's allowed to do that, because she doesn't. So that's one of the workarounds I was telling you about that people are doing. But I do think that I know my job isn't to help them with the performance measures, but to me that's what it's all about. And if they can get that in agreement, I think the data agreements would be a lot easier to get signed off on, and the sharing would become easier if they all had a fully understand objective of why this data needs to be shared and what we can do with it.
Thanks, Bob. Sabrina.
I think what I've learned is breaking it down to just a dispatch center in itself is the details. Make sure you are checking the details of what you're doing. Because you see the overall picture, and we have the overall, we have 98, we have all these overall things. But when you break it down to the center that you're at, what are the details that you're doing to make sure it's in place properly, to make sure it's giving you all what it can, it's working for you exactly how it can. Because there's so much that it can do for you. Are you utilizing it well enough? Are you taking advantage of it, of what it all can do? And that's in the details.
Thanks. Bob?
So I'll just use the word encouraging again, and I think it's encouraging that we've got this opportunity. We see you have the right people involved here and in different groups working on this. We can't let it go. I think now is a prime time to be able to work on this, work on the data, what's needed, what can be shared. From state to state, it changes. Maybe there's some legislation that's needed at a federal level to that may be difficult. But how can we bring that the best practices, I guess, and the comfort to the local agencies that are handling calls that come in on 911 and help them understand the resources that 988 and that are out there. And so we just have to keep working on it.
Thanks, Matt. Brian?
Really start with a good foundation. Identify your processes, your procedures, and then continually reinforce. It's something new, it's a change, you just keep going at it, never let people forget it, and you'll get your best data that way, and you'll get people to really think about it when they're taking these calls with the process.
Thanks, Brian. So I'll turn it back to Arnie and Carly. As you run the TIA Center, right? What are you seeing and what are some of the lessons learned from your perspective?
I think what's encouraging for me is just seeing how common these programs are becoming. I mean, we, provide the technical assistance for the Connect and Protect Justice and Mental Health Collaboration Program grant track, which specifically funds police mental health collaborations. We have 93 active grantees. That's a lot of programs, tribal nations, and, just so much variety. I have students now that are doing internships in co-responder programs. 5 years ago when I started teaching, that wasn't a thing. So seeing how this is becoming the norm, but I think also one of the big lessons learned is that this really has to be, the fourth responder, right? We have police, fire, EMS, and we have mental health. And it has to really be seen as the fourth responder, not just an option that you can utilize sometimes, or if, it has to be built into the system that way.
Yeah, and for me, it's really getting back to the basics. I know data is important, but behind every data, every tick, is a person that's called for help. And we cannot lose focus of what we're doing and who we're here to serve. So for me, it's personal. We'll do the best we can to always work closely with agencies and be inoperable as we can. But at the end of the day, it truly is about serving the members of our community and just loving on them because they need it. We saw it last night just walking back to the hotel. It's a problem that we're not going to overcome overnight, but together we can do it.
Excellent. So any last minute questions? All right, so let's give a balanced round of applause and thanks for coming.
Yeah.
Thank you all very much.